call this Board of Health.
Recording in progress.
Now, we're going to call this Thurston County Board of Health meeting to order.
Can we make sure and turn on the camera and audio on Zoom?
Tech support friends, can you please make sure that the room is pinned and that the video is on?
I'm blind from back there.
Okay. Welcome everyone to the Thurston County Board of Health meeting for April. I want to do a quick round of introductions just so folks in the audience and folks tuning in from home know who's on the board and in the meeting. Let's start over here on this side.
Hi, I am Beth Harvey. I'm a pediatrician.
Lynn Nelson, I'm a registered nurse, Board of Health member.
Ty Menser, County Commissioner.
Carolina Mejia, Board of Health member.
Robin Vasquez, Board of Health member, and Lacey City Council.
Emily Klaus, Thurston County Commissioner and Board of Health member.
Good afternoon, Ray Peters, Squaxin Island Tribe Board of Health.
Hi, my name is Perla Newton. I'm a nurse and I'm a Board Health member.
Heidi Canelo, licensed mental health counselor and Board of Health member.
Damian Abdul Malik, Thurston County Health Officer.
David Bain, Public Health Director.
And Commissioner Edwards, you're online.
Gary Edwards.
Welcome, everybody. Can I get a motion to approve the agenda?
So moved.
So moved. Second.
It's been moved by Commissioner Mejia and seconded by Board Member Peters. Any comments, questions about the agenda? No? All those in favor, please say aye.
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 Any opposed? Any abstentions? We have an agenda. First order of business, we have the proclamation and recognition of International Transgender Day of Visibility. So we wanted to read the proclamation, and then I think we're gonna have a speaker, some guests come up and talk to us about this. So why don't we start on the opposite side of the room today? Heidi, would you like to read the first whereas?
Whereas International Transgender Visibility Day was founded in 2009 to acknowledge and honor the successes achieved by transgender people by the US-based transgender activist Rachel Crandall, a licensed psychotherapist and the executive director of Transgender Michigan, and
Whereas organizations across the world celebrate International Transgender Visibility Day as an annual day to celebrate the accomplishments and victories of transgender and gender nonconforming people, while raising awareness of the work still needed to save transgender lives. And
Whereas International Transgender Visibility Day is intended to recognize and celebrate the work being done by transgender advocacy groups as they fight for dignity and equal rights for members of the transgender community, to build inclusive and healing spaces, and to protect and defend those who are most vulnerable. And
Whereas Thurston County recognizes the significant contributions made by transgender people and affirms they are vital members of our community.
Now therefore be it resolved, the Board of Thurston County Commissioners, Board of Health, hereby proclaims March 31st as International Transgender Visibility Day in Thurston County and urges residents to honor the lives of those lost through participation in community service and remembrance ceremonies. Adopted the 12th day of March by the Board of Health. Yes. I think we previously discussed this item last month, but we are revisiting it today. So I wanted to invite Lucas Miller and Larry Cronquist up to join us here at the Board of Health round table square shape and speak a few words.
Ladies and gentlemen, members of the board, thank you very much for having us today and for issuing this proclamation at a time when forces bent on destroying democracy are using the trans community as a cat's paw in their quest for power. It is always reassuring to know that public bodies like this one are willing to stand up and affirm our rights to life-saving healthcare, the right to change gender markers on our driver's licenses, and the right to live with dignity, in our true identities. The point of having a visibility day is that we need to be seen. We need to be understood as vital members of a community and of a nation. We need to be, seen by, the entire community in which we move. And when public bodies like this one, issue statements in affirmation of our right to be here, to be part of public life, and to live with dignity on our own terms, that goes a long way toward not only affirming the transgender community, but every community that is currently under attack. And make no mistake, when they are allowed to come for the rights of one group, they will come for the rights of all. So by making this proclamation, you are doing something far more far-reaching than simply affirming members of the transgender community here in Thurston County, but the members of transgender community nationwide and the members of all other historically marginalized groups. So once again, thank you very much. And again, thanks to the Lacey City Council who issued a similar proclamation, was it 2 weeks ago?
Recently.
Yeah. And we hope that this will encourage more groups like this one, and encourage those who are fighting for the rights of all of us. So, thank you.
Thank you so much.
Sure.
I think we wanted to take a minute to take a photo and provide you with a copy of the proclamation. So we're gonna stand up and do that. We're gonna go over there.
So we'll do the photo here in front of the leader. Squeeze in. Do like 2 rows, like taller people in the back, shorter people in front. I'm super tall, so I'll be in the back. That's pretty
Oh, thank you.
Can you get us all in the photo with that column?
My column is out of the way. Not covering anyone. Okay. So 1, 2, 3. So I'll take one on here and then we can take some other ones too. So 1, 2, 3. Perfect. Okay, and then we'll take another one. My turn. We'll make some corrections to it.
I know.
Cupcakes appeared. All right, thank you very much. I want to move us on to the next item on the agenda, which is a proclamation we're going to be reading, recognizing Sexually Transmitted Disease Awareness Month. This time around, let's start on the other side of the tables.
Sexually Transmitted Infections Awareness Month presents an opportunity to elevate awareness and enhance comprehension about STIs and their impact on individuals, to diminish stigma, fear, and discrimination associated with STIs, and
Whereas STIs have shown a significant rise in prevalence in the United States. In the year 2022, over 2.3 million cases of syphilis, gonorrhea, and chlamydia were documented in the United States. And
Whereas STIs are the second most frequently diagnosed and reported notifiable conditions in Washington State and Thurston County.
And whereas in the year 2022, over 1,000 cases of syphilis, gonorrhea, and chlamydia were documented in Thurston County. And
Whereas STIs represent a significant public health issue as a substantial number of individuals may be unaware of their infection status unless accurately diagnosed through testing. And
Whereas discussing sexual health and history with healthcare providers helps connections to appropriate testing, care, and counseling services, reducing disease-associated consequences such diminished reproductive health. And
whereas Thurston County recognizes STI Awareness Month to equip individuals with the necessary tools and information to promote sexual health through testing, diagnosis, and appropriate treatment. And
now therefore be it resolved, the Thurston County Board of Health hereby proclaims April as Sexually Transmitted Infections Awareness Month in Thurston County and encourages all community members to prioritize their health by getting tested regularly in order to safeguard their well-being as well as that of their partners.
Adopted this 9th day of April, 2024.
thank you. All right, I believe we've got guests joining us to speak about this issue as well. We have Zant Bryant on the line and Katrina Miller. Zant, can you hear us?
I sure can. Can you hear me?
Yes, and we can see you.
Yes, I came on camera for to say hello. I'm sorry that I can't be there with you. Unfortunately, I had a health emergency of my own this morning that makes it difficult for me to drive. But let me go ahead and get started. I'm Zant Bryant, the Sexual Health and Prevention Program Manager for the Office of Infectious Disease at the Department of Health. I'm joined today by Katrina Miller, who's our Western Washington HIV/STI Field Services Coordinator. And I believe our syphilis epidemiologist, Silas Heiser, was going to attempt to join you all in person as well. I want to thank you for welcoming us to this meeting of the Board of Health. We're grateful to join you today to share information and our gratitude to Thurston County Public Health and Social Services related to National STI Awareness Week, which is next week, the 14th through the 20th, and National STI Awareness Month, which is April. DOH is fortunate to be able to work in partnership with the folks at Thurston County Public Health and Social Services to support members of the community and the medical care system in detecting and treating and preventing STIs. Although all STIs, including HIV and Mpox, are of concern for the communities we serve, we wanted to call special attention to syphilis. Reported cases of syphilis in particular have increased across Washington state, including here in Thurston County, across the last several years. Reported syphilis cases in Washington state have increased by 153% since 2017 and by 292% in Thurston County across that same period. Our disease profile has shifted across the last 5 years, and that means that where syphilis was once an epidemic primarily experienced by gay and bi men and members of their sexual networks, the majority of syphilis cases in the state are now reported in people who say they have partners of the opposite sex. Many of those affected are among those most in need in our communities. For example, people who are unstably housed and who may be affected by substance use disorders. This means that Washington state, similar to the rest of the nation, now sees increasing cases of syphilis among cisgender women. When we see an increase in syphilis among pregnancy-capable people, what often follows is an increase in congenital syphilis. And I note that here in Washington, cases of congenital syphilis have reached historic record levels recently. Reported cases of congenital syphilis in Washington have increased from 6 cases reported in 2017 to 58 in 2023. Among those 58 were 2 cases reported from Thurston County. This is especially alarming when we acknowledge that among the reported congenital syphilis cases are stillbirths. Congenital syphilis can result in stillbirth or neonatal death. Because congenital syphilis is completely preventable through prenatal testing, which is required by state law, it is a proxy for us for concerns with access to medical care for people who are capable of pregnancy. The existence of a new and alarming epidemic among people with partners of the opposite sex is parallel to the continuing disparate effect of STIs among gay and bi men and their sexual networks, as well as significant disparate impact for people of color in Washington state. Members of the Office of Infectious Disease are grateful to collaborate with Thurston County to help members of the community who are diagnosed with syphilis, as well as HIV and other STIs, to understand the conditions with which they are diagnosed, to access medical care and other supportive services, and to help people close to them who may be exposed to these infections to learn their status and take power over their health. We also continue to make it our mission as an office and as a field as a field to partner with local health jurisdictions like Thurston County and the medical care system to expand access to testing and to medical care for those most affected or at risk of acquiring these conditions, and to make services available, accessible, and acceptable to those who are disparately affected by sexually transmitted infections, including HIV, as well as viral hepatitis and drug overdose. Thank you for your partnership in protecting the health of the people of Washington State and Thurston County. The Department of Health seeks to continue to be a supportive partner to the Thurston County Public Health and Social Services and to the people of Thurston County and communities across the state.
Thank you, Zant. Can I ask a few questions, actually, just to make sure I heard you right?
Please do.
Anyway, Silas is here in the room. She did join us. Did you say that we've seen a 272% increase in syphilis cases in Thurston County?
292% across the last 6 years, yes.
In 6 years. That's wild.
Syphilis has skyrocketed in Washington State, especially during the pandemic. We believe that because people struggled to access medical care during the pandemic, that led to continued spread for folks who could not access testing and treatment, or who avoided, in some cases, medical care for fear of healthcare-acquired infections of COVID, for example, or being around other folks. Additionally, because of the nature of the population affected, when we think of people who are affected by substance use disorder and who may be unstably housed, those are folks who are sometimes stigmatized in the medical care system and who may avoid medical care because of the experiences that they've had in the past.
And you had said also that people who give birth, if they are infected with syphilis, it is something that is testable during the provision of prenatal care. Like it could be identified and treated during the prenatal period of time.
Yes, that's correct. Congenital syphilis is completely preventable in that if we test someone for syphilis early in the pregnancy and we treat them, then the effects on the fetus and therefore neonate can be avoided. The later that someone acquires syphilis during pregnancy, the greater the danger to the baby.
And if they don't find out that they have it, it can have really terrible consequences for the baby.
Unfortunately, so there can be significant health consequences for the baby, anywhere from simply treatable infection to developmental delays or birth defects, or unfortunately stillbirth or neonatal death.
Well, thank you for providing us with that information and for being here. I wanted to invite Katrina or Silas if you had any follow-up comments.
I'm Jen Young.
Oh, I'm sorry.
You're fine, Silas, over there.
Oh, sorry.
I'm our senior epidemiologist for communicable disease for public health and social services. I have a couple stats that are Thurston County specific. Zant touched on a lot of it, so I won't go over everything again. But in 2022, Thurston County had 1,135 STI cases reported. Syphilis cases do not indicate there will be a significant decline in the near future. We had 51 cases in 2019, over 100 in 2022, and then preliminary data for 2023 shows a slight decline in morbidity, but not by much. In 2023, the majority of syphilis cases continue to be identified in the 35 to 44-year-old range. It's closely followed by 25 to 34-year-olds. Preliminary data shows that there was an increase in chlamydia cases from the 817 cases that were reported in 2022. In 2023, the reported chlamydia cases, the largest proportion of cases continues to be diagnosed among female gendered patients and among patients between the age of 15 and 24. 2023 preliminary data also shows there was a slight decrease in gonorrhea cases from the 253 cases reported in 2022. Gonorrhea cases, the greatest proportion continues to be among males in 2023. Of the 59% of male cases, 58 were identified as MSM based on the reported sexual behavior. In 2023, the greatest proportion of gonorrhea cases fell between 25 and 34 years old of age range. So currently in Thurston County Public Health and Social Services, we do not offer testing and treatment options outside of our drug user health program, which specifically focuses on hepatitis C and HIV. Clients are normally referred to their Planned Parenthood, Olympia Free Clinic, or a primary care provider. An appointment for STI screening and treatment in Thurston County typically has a wait time of approximately 1 to 2 weeks. Our syringe exchange program provides condoms, rapid antibody testing for HIV and hepatitis C with care navigation. So there's a recognized need in Thurston County community for education, resources, and accessible testing and treatment options for STIs. Therefore, Disease Control and Prevention Division is currently exploring opportunities to improve access to treatment in order to meet the growing demand and reduce STI cases. We want to thank DOH for joining us and giving some insight into the state level view for both virtually and in person. But that's it. Thank you.
Is it? Go ahead.
Okay. Thank you. Thank you, Jen, for those great statistics. I have a question, and I guess I'm not sure if it would be you or David. Is the reason why Thurston is not as widely available, is it because of the Foundation of Public Health and it counts as a direct service if we're actually doing testing? Or
Yeah, it's not an area that we have a lot of direct funding for. It's an area that there are specific grants that help support that work, and FPHS has not traditionally been one for that particular part of services. So it's something that is a need for us, as Jen said, and we'd be interested. I mean, the state's been really supportive, but we don't have a lot of grants that are specific to this work that we've done in the department.
That's one of our main initiatives for this year, is we're looking into different opportunities to expand.
may I ask, like, what kind of opportunities?
Yeah, so there's a couple, there's, I don't know if Dr. A wants to jump in, but there's different companies that offer kits or at-home testing. That's been FDA approved, so there's initiatives in public health funding for that. I think one of them is I Want the Kit, and a couple other ones. We're also looking into 340B Med funding for offering EPT, which is expedited partner therapy. So being able to treat those that are exposed to STIs, which Dr. A as our health officer would be running. And there's things like that we're looking into. So nothing solidified as of right now, but we do have meetings this week and next week. So it's moving.
And if I may add, the Department of Health is very supportive of this, and we do provide expedited partner therapy supplies to a number of jurisdictions. So Thurston County would not even have to purchase those medications if they wish to acquire them through DOH distribution. We already drop ship Vicelin for syphilis treatment to Thurston County, and are grateful to Thurston County for housing that medication for us when we need to ferry that to providers to make sure that there are no barriers to the treatment of syphilis.
Thank you.
Yeah, we before the pandemic used to have expedited partner treatment in our clinic, and we got it through state, through county, I think, and it was really helpful. I think there are people who don't get treated if you can't just like give this to your partner, and also some of them it just expedited getting them treatment because there were all these confidentiality issues with them getting the parent having to go take them to the pharmacy to pick up the prescription or that kind of thing. So that would be wonderful if we could reinstitute that.
Absolutely. Just let us know. My team is part of that distribution work, and the moment you contact us and let us know that you need supply, we will move to support you.
I think I have a meeting set up with Lena next week, Zant.
Perfect. She's exactly who you need to talk to.
So it's not an issue of provider availability in this case. It's really just getting the kits in the right places, into the right hands.
If I may, I do think that, across Washington state, most of our local health jurisdictions no longer have public health STI clinical services available. And for a lot of folks, noting the long wait times for appointments that I believe Jen pointed out, in a lot of cases when folks have symptoms and need clinical services as quickly as possible to intervene in their course of infection and in the spread of infection, when public health clinical services are available, that really presents opportunities for people who struggle with access or struggle with talking to their own provider about their sexual health because of concerns about confidentiality or social desirability.
Commissioner?
I have another question. I guess this one's more for Department of Health, right? You are coming up with the standalone kiosk, thank you. The send-along kiosk, there's one in Tenino. Could that be a place maybe of partnership as more kiosks become available that these kits can, can be placed in there and that be a possibility?
I believe the funding for the kiosks we don't know the end date of it. So I think Katie might have more information on the kiosk. She helped us get those set up.
Yeah, so we had been looking at.
Yep, come on up.
Come to the front of the class.
I thought I got out of it.
Sorry, Katie.
So as far as the kiosk, we had been waiting to stock it with different materials such as naloxone, condoms, fentanyl test kits, STI kits, until we know the end date of the kiosk. Right now, the kiosk is placed through, I believe, the end of June. The funding needs to be renewed. So we were waiting to see the directive that comes down from the state and the State Department of Health as to whether the kiosk will stay, be moved, expand before we stock additional supplies. We didn't want a situation where we put in really like vital healthcare supplies and then the kiosk gets yanked and folks no longer have access.
Thank you. Thank you. Dr. Harvey?
I almost wonder too if there would be a way to organize the medical community on expediting treatment and testing, because it's very easy. I mean, obviously there's more you would like to provide, but like if there's that long a wait for people, maybe there's a way to at least get some testing and treatment earlier. So maybe we can think about ways to collaborate and get like some systemic ways that maybe there's some urgent care sites we could do it, or maybe there's certain clinics for certain ages or rotating schedule or something.
Yeah, that's a great idea.
Yeah, let's explore that.
I would go back to your point that you made. It's mostly uninsured and underinsured that are the big gaps in trying to get treated. So if you talk to any of our nurses or case investigators that are speaking to the patients, those are the patients that struggle to find treatment because the hours for free clinics are scarce, or they can't get an appointment, or they can't afford it. So having EPT out of Thurston County or having a testing or treatment opportunities for that would make things a lot easier, not only for investigators, but for the community.
This may be an outside of scope question, but do you have a sense of whether or not the people who don't have insurance or who are underinsured and therefore not seeking this kind of care would be eligible for like the Apple Health program, but maybe they're just not aware of their eligibility or what the process is to get insurance coverage?
That's part of it, is a lot of people need insurance education or help signing up. We do have case navigators through Pathways we can link them to, but we only have 2. So
you have to come in and ask for help first, right?
Mm-hmm.
So if you know that you're eligible, then you don't come in and ask for help to assist you getting coverage.
Yep. Well, and to Zan's point, this is a whole nother conversation another time about the shift in public health nationally away from direct services, away from public health clinics. I'm obviously biased, but I think one of the consequences of that is that there's a whole group of people now that don't have access to these basic services in a way that they did before. And this is not to disparage, of course, the free clinic or other options. It's just we could theoretically provide more access, more stability, that kind of thing. And this is not just Thurston County. Again, this is a nationwide trend for the last, 10 years or so of that shift. And so I guess I'm not necessarily advocating that we have to go all the way back with the pendulum, but I do think that we're seeing that there's real big gaps in the system that I think public health can at least be part of covering those gaps. And so we'll do our part here in terms of trying to be an intermediary and trying to provide the kits, but I do think there's a bigger conversation about what services we provide. And I know that DOH is also contemplating this question mark too about what role health has in that, so.
Is the shift?
And if may I build on that as well? I apologize. It depends on the trajectory of which infection we want to intervene in. I think it's an access issue in one way for chlamydia and gonorrhea, for people to get treated in a timely manner. For syphilis in particular, this really centers heavily with our houseless community. And folks in the houseless community are largely seeking medical care through emergency departments. And so that looks quite different. And so having low barrier care access points for people who are at risk of acquiring syphilis and HIV, for example, is really critical as well.
And I do want to kind of highlight that I've had, questions and inquiries from providers throughout our community, and there are folks that are interested both in testing pathways for syphilis, kind of focused on that, and there are also folks that are interested in thinking about, like, if you're only seeing a patient that one time who's symptomatic and you might not get that syphilis test back, while the patient's in an emergency department or urgent care setting, wanting to support folks in, starting treatment for folks that are symptomatic,
Sort of
especially if
prophylactically.
they might not be able to get the result of the test, or, they might be left to follow up, and that might be your one opportunity.
The harm of prescribing antibiotics to someone who might not have the disease is far less than the impact of the disease.
Not just that, but when people are exposed to syphilis, and this is also true for gonorrhea and chlamydia, we have to remember that treating people who are exposed aborts incubating infection. And so when we have folks report to medical care who tell their clinician that they are exposed, making sure that those folks receive treatment regardless of test results helps not just treat those who later turn out to be positive, but also helps prevent the spread of disease.
Madam Chair, I just want to call it, and this is a great conversation, and I always hate to be the
Keeping us on time.
closing it down, but we do have another presentation versus the proclamation discussion.
Well, I will draw us to a close. Thank you for the prompt, but I really appreciate this discussion. This is an important issue in our community, and I'm glad we've got so many great people working on it. And now.
Thank you for having us today.
Yes. For those of you that are in the room, shall we take a quick photo before we move on to the next item on the agenda? And I did want to welcome Commissioner Fournier. Thank you for joining us. I hope we see you there.
Thank you.
I just stood there and smiled. I didn't do anything.
Why are they touching this? Oh, for the transgender. Oh. To test this, but the ones that are the transgender colors.
All right, let's proceed to the next item on the agenda, since we're all finding our seats again. I'm going to open it up for the opportunity for the public to address the Board of Health. Do we have anyone signed up for public comment? Last I checked, we did not, but. Okay, and nobody online? All right. Well, just to be clear, there is always the opportunity to address the board via public comment if you have something you want to come and talk to us about. Next item on the agenda, we have the Emergency Management System update and naloxone administration presentation. Can I ask Ben Miller-Todd to join us at the table?
Madam Chair, if I may.
Please.
While they come to the table, there are treats and people are invited to.
Partake of the treats. Okay, they were mysteriously appearing, like, right? Just popping up here and there in the
Commissioner
room.
Klaus gets the credit for these.
For the mysterious treats.
Probably a retreat.
Adds a little bit of excitement to the meeting. Just cupcakes randomly.
Those ones are vegan. That whole container is
chocolate
vegan.
in.
The rest are not.
Okay.
Yeah.
All right.
Good afternoon. I believe there should be a presentation that's being brought up. I'm sorry to cut your previous discussion short. It was riveting, and it was very necessary. With that being said, I'll hold off until after the talk.
That's probably good.
My name is Ben Miller-Todd. I'm the Director of Emergency Services for Thurston County. I oversee emergency management and Medic One. And just to frame this conversation, we wanted to do a quick briefing regarding one of the topics that is heavily integrated with public health and the public health response regarding opioids, and walk through some of the components that now I'm using emergency management, Medic One is doing in terms of currently doing in our structure, as well as have a discussion over what our future plans are for naloxone distribution and also integration into the system. As we walk through this, I please welcome you to ask questions. This is meant to be a discussion. There's just a few slides and it's about 14 that we'll go through very quickly, just to give you a quick overview of the EMS system, because this is our first conversation, just to set the playing field and then walk into that. Additionally, with me today is Dr. Larry Fontanella. He's the medical program director for Thurston County Medic One. At the end of the discussion, he'll be saying a few words after the quick presentation. With that, I'm sorry, I do not have a controller. Okay, sounds good. We're good to slide on to the next slide. And actually, you can flip all the way to the EMS system overview, which is slide 4. With that, I wanted to jump right in. We're going to walk through the EMS system overview as we go through this process, also give you a little bit of the statistics that we see on the EMS side related to naloxone deployments, as well as a little bit of statistical kind of reference point for the process that we utilize, as well as steps moving forward that we'd like to integrate with public health and work on some messaging. With that being said, we all know that we serve a population of over 300,000 now, that we have 5 commissioners that are sitting at the table. However, I did want to call out that our community is made up of 12 fire districts. 9 of those supply primarily basic life support, or EMTs, to the community. 3 of those supply both, but we call those out as an ALS agency, but they supply both ALS and BLS services to the community. We're very blessed and lucky to have a Medic One system that fully integrates all of those agencies and the coordination that's involved with that. With that being said, we additionally have 3 other private carriers that help us with interfacility transports between our facilities that are in Thurston County and our hospitals, as well as providing transport in the pre-hospital sector from scenes into the hospital. Lastly, our system's made up of about 650 EMTs and paramedics. 90 of those are paramedics, and about 560 of those are EMTs. And so this is a fairly large and robust system to support the 6th largest county in the state. If you want to flip to the next one. Sometimes it's missed, and I just wanted to very quickly go over this. No tests after this, but this is our governance structure. This is kind of our reporting structure that goes up to the Board of County Commissioners. A lot of times it's missed that the EMS Council, or the Emergency Medical Services Council, reports up to the Board of County Commissioners, and we're asked consistently, how did they vote? But all the decisions that are made with the roughly 100 individuals involved in the system and the variety of different committees and subject matter experts are kind of underlying this as a reference point. And so when you look at the tip of the iceberg, the questions asked, how did EMS Council vote? But in all reality, the 100 or so people that are made up of all these committees and subject matter experts that are passing this along are involved in the EMS structure as a whole, involving our community. Next slide. You are well versed in the next slide, but I threw this. Oh, sorry. Did you have a question?
Advanced Life Support Contract Negotiations Committee.
Yes. That is an ad hoc committee that's established within the bylaws. We stand that up when we do contract negotiations with our 3 ALS services. For those at the table who don't and haven't heard about the configuration of our ALS services, we do a county-wide deployment of ALS services. We contract, the county contracts for those services with our 3 ALS providers, Olympia, Lacey Fire District 3, and Tumwater. With that, I'll go over very basically when we talk through this, and this will play in a few slides. When we're talking about incidence, prevalence, and really recovery rate, we're looking at a variety of different measures that we're taking in the EMS sector to reduce a variety of different components of opioid use disorder, opioid overdoses, and the epidemic itself. First off, we want to stop the number of people that are becoming addicted, so that we and are diagnosed with opioid use disorder. We want to stop the flow. We want to stop the input, and that is that new case, that incident that we're placing into that bucket time and time again. And a large part of that has been changing how we look at pain management, how we track opioids in general, and federal regulation, state regulation, and others have helped to address it, but we're still seeing an uptick in the incidents within our community. Additionally, we want to address proactively those that are now currently have or are associated with opioid use disorder. We want to prevent mortality, which is listed here. By and large, that's done through naloxone and other measures to help reduce the mortality in our community, as well as increase the recovery rate. So there's a variety of factors here, and those are some of the components that we want to discuss as we walk through this process. Just a couple statistics. What we want to do is provide you with the groundwork for some of the decision-making process that we have. These are 152 cases. So in 2023, we had exactly 579 cases or individuals that we in the EMS system provided Narcan to, okay? As a surrogate that is looking at, the response to opioids. With that being said, this is the first 152. This is where naloxone was provided prior to EMS response. And one thing that I wanted to point out to you as we walk through this presentation is about 48% of those total were transported to a local ER or facility for treatment. And then about exactly 48% of those were associated with those that left against medical advice from the scene, left the scene, or a variety of other reasons, but did not seek any further treatment. As we slide to the next slide, you look at that Narcan administration by EMS. This was the 427 other incidents where we supplied naloxone to these individuals. You see a significant, a 10% increase in those that were transported from 48% to 58%. And we also see a reduction of about 15% in those that left against medical advice and left the scene. One thing that we do want to discuss is the increase in mortality that we're seeing. And to make it clear that the cardiac arrests that were associated with these, we're finding more and more prevalent that there's a delay in 911 response. And that's something we want to talk about when we're talking about early activation of the 911 system, early activation of medical care for these providers. I'll take a quick breath, yeah.
Do we have any data on the geographics of these cases? Is the length of time between the 911 response a result of some of these being in rural areas, or is that not a big?
In broad picture, the vast majority of these, over 85 to 90% of these happen in our urban area. In terms of the response statistics, on our average response times for our ALS units are about 7 minutes and 12 seconds. That's countywide. But when you bring that into the urban core, it's about 5 minutes and 55 seconds.
Quick.
All right. To put that into perspective, and the reason we wanted to talk about this, these components, were that if you slide to the next slide, there's just a couple statistics that I wanted to, it's a day of statistics, I can tell. Hopefully not muddying the water. But one of the most, I would say, profound statistics that we found when you look at EMS naloxone deployment and overall one-year mortality was that there was a study that was done in the Boston area over the course of about a year and a half. It looked at 9,700 cases where EMS had an interaction with the patient, had given naloxone, and then the subsequent tracking of one-year mortality. It is absolutely profound to me that almost 1 in 10 of those died within the first 3 days following that interaction. The first 3 days following that interaction, there was a almost 10%, an 8.3% mortality associated with that contact and walking away and trying to route these individuals towards recovery. Those are the statistics that we're dealing with. Subsequently, in the next 4 days to 365 days, there was an additional almost 7% mortality associated with that. Aggregately, 15.2% over the course of a year.
Are
So
these the patients who were transported or?
this is
All patients that
all.
receive naloxone.
Yep, all patients that receive naloxone in the EMS arena. With that being said, if you slide to the next slide, in perspective,
Well, and
oh, sorry.
I'm sorry. They did exclude patients that they were given naloxone for altered mental status or unknown down. So they excluded those people.
We're not
And then
clearly
I don't think if they did not survive the initial EMS contact, I don't think those were counted in the original analysis.
What I was getting at was, were they people who were treated and then either left against medical advice or were released? as
Some
well?
were transported to the hospital and some did leave against medical advice.
Yeah, absolutely. To put that into perspective, and this is one of those components that just to kind of let it sink in, the gravity of these statistics is that those that were associated or as a comparison, a study of patients with ST segment elevation or myocardial infarction, those that had a heart attack, who received primary percutaneous coronary intervention, so that also received care or treatment, found a 1-year mortality associated with that of 7.3%. And so when you're looking at when you're looking at the gravity of the situation, you're looking at the mortality associated with this, you're looking at how do we promote a path towards recovery as best as possible. With that being said, there's a couple Medic One initiatives that I wanted to walk through. I know that I'm not going to go into detail with this. This is a reference point for this group. However, there's a variety of initiatives in 24 and 25 that we'll be going through. And if you want to switch to the process in terms of protocol development, one more slide. One more slide. Thanks. We talk about the process involved with how do we implement some of these components. One thing that we did call out in the previous slide, and I'll just put it up there, it takes us, we identified that we wanted to do BLS Narcan to the EMS Council starting in September 20th of 2023. As we walk through that process and that algorithm, this is just a snippet. This isn't all the steps. This is a snippet of those steps that it takes to integrate or create a protocol, integrate that protocol into or identify the source of funding for equipment or medications, to also do the training analysis to train, when you go back, 650 providers in 15 different agencies across the system, transporting to 4 different hospitals. How do we integrate that in a seamless fashion and do that in a stepwise fashion? And then additionally, how do we make sure that we can pay for it, make sure it's sustainable? And lastly, if you switch to the next slide, the hard part is training each and every one of those providers and making sure that we get through the state process of protocol approval, which we're currently in now for our last set of protocols that we started over a year ago. We're in the state approval process, just about ready to complete that up, and then we can go live. And so when we identify the process when we're going through it, it's imperative that we follow this as closely as possible so that we don't have mixed messaging, that our stakeholders are well informed of the decisions and changes that we're making, and that we're making sure that we practice medicine as seamlessly as possible throughout Thurston County in a stepwise fashion. Yes?
For the sake of our new board members, could you maybe describe basically what the current state is and what it's changing to? So what is this protocol evolution getting us from point A to point Z look like?
Absolutely. It's I think I even teed it up if we go one more slide.
Oh, look at that.
It looks at specifically what does this look like, and if this doesn't answer your question, let me know. But it looks at what we're headed towards over the course of the next year. So what's currently in the pipeline and going to be approved, what's going to be approved by this time next year in terms of its implementation, and it's tying it back to how are we addressing incidence, mortality, or death rate and recovery. And so those were the components that we really needed to figure out how we integrate best with public health, and we'll do moving forward. But what does that look like when we're doing, how do we reduce the incidence? Well, part of that is making sure that we're not administering opioids in the EMS setting for pain management, that they're used extensively for pain management, but we're now administering an opioid to somebody who's naive to opioids and starting down, potentially being that introduction to opioid use disorder. And one of those things is this medication is a non-opioid pain management medication, so we have alternatives to opioids on our paramedic units when we're treating pain. So how do we have alternative measures in order to be able to treat pain?
Ketorolac?
Ketorolac is, think of it as high-powered ibuprofen.
Injectable ibuprofen.
Yeah.
Okay.
So, with that being said, we also want to reduce mortality. Partnering with public health to address the messaging in our community to make sure that we're activating 911, to make sure that we're getting EMS on scene to be able to treat these individuals, as well as looking at BLS Narcan protocolization, which was messaged again, I said, on September 20th, 2023, and also a Leave Behind Narcan program, where that if we are not able to have individuals come with us, or we're not able to transport them, that we still have access to replace the Narcan and leave it behind that they may have used previously for the overdose we were called for. So making sure that we're not leaving the scene without replacing that Narcan and have that available to our providers in the field. Lastly, to improve the recovery rate, I'm sure some of you have heard of Suboxone, which is a drug to, again, help the process of recovery and help to reduce mortality. This is another component that the state has approved in the scope of practice for paramedics in the state of Washington. And we're looking at protocolizing this as early as possible with the current process.
How is Suboxone administered?
It's a tablet. It's a film that
You
melts
put on
in
your
your
tongue?
mouth.
And does it boost the beneficial effects of
it's-
naloxone, or is it different?
It's different. So opiates act on an opiate receptor in the body, right? And so some substances like heroin, morphine, they're very strong agonists. And then you have, meaning they attach to the receptor, they cause people to get pain relief or euphoria. You have something like naloxone, which binds the receptor and kicks off the opiates and then blocks that receptor. So then they can no longer get the effect of the drug, and that's where naloxone comes in. Buprenorphine is an agonist-antagonist, so it has actions of both. Typically, it can be used for pain control, but mostly in the setting of opioid use disorder, it's helped to curb cravings. So it can take away the withdrawal symptoms that patients have that really drive them to continue to continue to use that substance. And it can cause a withdrawal. If you see someone that's got a very high tolerance and they get put on buprenorphine, they could go into withdrawal from the buprenorphine. But the other thing is, if we do end up using it as a leave behind or dispensing it, one of the things that is potentially helpful is that it's agonist-antagonist. It can actually block the effect if they continue to use. So if they get fentanyl after taking buprenorphine, they're not going to get the same effect that they had from the first time they used it.
Sticks around in the body longer than Narcan. I didn't realize that buprenorphine and Suboxone are the same thing.
Sorry, yeah. Suboxone
Random
is a
name.
combination medication with buprenorphine and naloxone, isn't it?
Yeah.
Yeah.
Okay, yeah, I have heard a little bit about the beneficial effects of buprenorphine. That's what that is, okay.
And so we're looking at being early adopters in that process to make sure that we have that available to our residents.
What does that protocol look like? Like how many days, and then what is the process for hooking that person up with a treatment center and follow-up?
I'm really glad you asked that. Part of the development process on this one takes a little bit more time and effort because we're actually establishing new relationships that we would not normally have had. So what does it look like once we have administered Suboxone? What does it look like to make sure that we're tying that individual with continued treatment and making sure that they have access almost immediately, as nearly as we can, to services?
What counties in Washington State are doing that now?
I know that I can only speak to two at this point in time. King County has an introductory protocol, as well as there's some studies that are currently being done in Spokane.
There's a pilot in Spokane, and yes, in King, they're developing the process to have it all level providers being able to dispense, was that the right word? Administer. Suboxone. We have to be careful because you cannot dispense, you have to be a pharmacy to dispense. We can administer.
So with this response plan, do you have a theory on which part will impact the mortality rate the most?
I think when you're looking at how we treat, and part of this is kind of the next couple slides as well, that we put into here. I truly do believe in the broad distribution of naloxone itself, I think has reduced mortality. But I think the question still remains, based on the statistics, how do you reduce mortality beyond an incident or two incidents? And how do you have long-term reduction in mortality when you're looking at the 1-year mortality? So how do we funnel the individuals that were doing an excellent job, and the programs that are being done with public health are doing an excellent job of doing, and how do we now take that to the next level? How do we say we want to not only reduce mortality from the incident or two incidents that we had, and ultimately we're still looking the gravity of those statistics, the first 3 days, the next 365 days. How do we now funnel those individuals into a recovery system instead of just being reactive consistently to the prevalence of opioid use disorder, to use the terms here?
So when you had the slides about evolution of protocols, and then David asked you what that means, where we're coming from, and then we started talking about opioid overdoses. Do these protocols relate to opioid overdoses?
These protocols that we're talking about today are directly related to opioid overdoses. By and large, this is a process we'll follow for just about any medication or skill that we protocolize for Thurston County paramedics and EMTs.
If you don't mind,
Yeah,
I'll go further.
absolutely.
I'll sort of, I think, try to outline the process as it is today versus where we see it going. So today, if someone has an overdose, they'll call 911. BLS and ALS get dispatched to every overdose in that case. So ALS is always coming with Narcan right now today. There's nobody that is refused the Narcan. BLS has a faster response time. So BLS gets on scene and they are going to start bagging the patient. So they're going to provide oxygenation. When someone succumbs to an opiate overdose, they stop breathing. And as a result of that, they become hypoxic, meaning low oxygen levels, become acidotic until their heart stops. By just introducing oxygen and ventilations, you stop that process, which is good. And then when the paramedics get there, the idea is they start an IV and they'll start titrating naloxone to get them breathing, get them sort of out of the danger zone, and then transport them to the hospital. The worst thing for me that happens in situations is when we completely reverse people. Because then when someone's awake, they don't feel well, they feel really horrible, actually, as a matter of fact, and they do not want to go to the hospital, by and large. We draw the comparison between MI and opiate overdoses, which is a great one to look at their mortality. The difference is for the MI patient, they usually know how sick they were. Absolutely. To them, they're having crushing substernal chest pain, they're diaphoretic, they feel like they're gonna pass out, they feel like they're gonna die most of the time. And they go through this whole ordeal and they realize how sort of sick they were. For someone that's had an opiate overdose, they went to sleep and they woke up feeling awful and they don't wanna go to the hospital. They don't see the anguish that their families were experiencing. So that's why there's such a high AMA rate, you know? Once someone is reversed, they have decision-making capacity, meaning we can't take them against their will. We can encourage them, but if they don't want to go, we can't make them go to the hospital. And we lose the opportunity to intervene in either the substance dependence or some of the other, I mean, when you look at that 7.5% mortality from day 4 to 365, or as I like to say, the 15% mortality from day 1 to day 365, that is part opiate overdoses. There are also some of those cases where they are succumbing to trauma. There's, because oftentimes there's, poor decision-making at play. Infections, they can get endocarditis if they're using injection drugs. We know all of these things. So it's not just the opiate overdose that will contribute to the 15% mortality in a year, but getting them out of that entire environment is what's, I think, gonna make a difference for the overall improvement in mortality. So to me, and we've looked at it because the potential has always been, the fear has always been, are there people that are being harmed because we can't bag them or we're gonna lose them before the Narcan gets there? And every analysis we've done, we've never found a single case. Even when we've had cases that are a longer ALS response time, because we've had them in Bald Hills. We've had cases in Lawrence Lake where it is a 12, 15 minutes, sometimes longer response time. But fortunately, our BLS airway skills are really good, and they're usually able to bag the patient with oxygenation and keep the patient alive until we can administer the naloxone. So that's the way that it is today. The way we would see it going in the next 2 to 3 years is we'll add BLS naloxone. I still have the fear though, because BLS naloxone is going to be administered intranasally, and it's 4 milligrams. It's very hard to titrate that. It is very difficult. We're going to try, but my worry is we're going to have more people that are going to sign out AMA as a result of BLS naloxone. That's my worry, but we'll see. The idea will be they call 911. BLS will get on scene first because they have a faster response time. We have the 12 agencies that are BLS and the 3 agencies that are ALS. Those BLS agencies account to something like 30-something stations around the county. So you look like you had a question.
No, Dr.
Okay.
Fontanilla, Commissioner Fournier has his hand up.
Oh.
Go ahead.
I can wait till the doctor's done.
Okay.
Oh, thanks. So the beauty of the tiered system that we have is we do get BLS with life-saving skills on scene very quick, and then ALS following. I'm going in the weeds, I apologize. So in the future, what we see is BLS will get on scene, they will start bagging. Their primary mission is still gonna be get this patient oxygenated. Once they have oxygenation attempted, if the ALS Narcan is more than 4 minutes away, or 3 minutes, I don't remember where we settled. Three. Then we were gonna say, okay, we'll start a dose of naloxone, and we're gonna start probably with lower doses and bag, give it a few minutes, and then repeat until either ALS gets on scene to provide IV, or the patient is breathing on their own. That's how we see it going, the naloxone piece of it in the future. The Suboxone, I think, I would love to see that happen. I think that is gonna be a few years in the making. I do think there's just some regulatory issues we're gonna have to deal with. But that would be nice, and the idea would be when we do have a case we come across that the patient either received naloxone or is interested in it, that we will be able to provide them a dose of Suboxone and connect them with the Suboxone clinic in Olympia or other resources. I forgot to mention, one of the other aspects that we're going to implement going forward very soon is leave behind packets. Right now, we don't have a packet that we leave behind. But the idea would be on any case that naloxone is administered, we give the patients also, whether they decide to come with us to the hospital or not, they'll get resources of where to get help from. There's something else I'm gonna say. Leave behind. I can't remember. Anyway, I'm sorry.
Before you go on, can you tell me what
Sure.
MI stands for?
I'm sorry, myocardial infarction, heart attack.
Thank you.
I think my question's very short, so I'll cut the line and just ask, do you foresee giving Suboxone from BLS staff? Or does it have to be administered by ALS right now? I don't know.
It doesn't, it's more regulatory issues. Well, not just regulatory, because it is a controlled substance.
It'd be another protocol.
Well, not just protocol, it has to get, so controlled substances, is it 2 safes? We have to keep it locked.
I'll make it quick.
Sorry.
It's an
It's
infrastructure
DEA.
issue, because you're stepping into the DEA realm. And so you're going into a controlled substance, and how do you do controlled substances? 126 additional apparatus outside of the 7 medic units. So it's a logistics and infrastructure issue.
And personnel, because we have 90 paramedics right now that administer all controlled substances in Thurston County. And we'd be talking about opening up to 500 providers that are now
I do want to,
managing controlled substances, and it just gets problematic.
yeah, thank you. I want to give Commissioner Fournier an opportunity to jump in, and then I see Commissioner Edwards and then Board Member Nelson.
Thank you. I just, I've got a lot of opinions about this, and I don't want to get into a debate. I don't want to spend too much time talking about what I think about a lot of what was just said. But I do want to thank the doctor for changing course and moving us forward. I do think BLS Narcan is important when we're giving Narcan to bus drivers and children to give out. I don't think there's any valid argument that restricting 90% of our EMS providers from being able to administer a life-saving medication for our, the number one cause of death in the county can hold water. But again, I'm going to refrain, and I'm going to say thank you both for moving the protocols forward. I understand that it takes a minute, and I will be patient. And that's I think it's important. But I do want to say that I'm not a doctor, I'm not a scientist, but typically when you're the only county doing it differently than all 38 other counties, then there's an issue, and there's something that needs to be, there's some positions that need to be dialed back. So the position of the past, it noted, but I think that kind of moving forward is what's important.
Thank you. Commissioner Edwards?
I guess my question was, I didn't hear anything about the oxygen and versus the air in the room only has, 22% oxygen or something. Does that come into play here?
The bagging?
It does.
Slide off.
Oh,
If you want to advance one slide.
It seemed like it was where we were going with the conversation. But yes, Commissioner, room air has 21% oxygen in it. So when we provide bag valve mask ventilations, we're giving someone 100% oxygen, which is much better for a patient that's hypoxic.
Yeah, okay, thank you.
Lynn?
Thank you. I have a couple of, I guess, clarifying questions, and I will say I share Commissioner Fournier's concerns.
Let me address them then, because I have strong feelings about it, if you'd like to.
I could tell you do, but could I ask a couple of quick questions first? The first one is that, and this is anecdotal in my experience, so I might be completely off and you might have statistics that tell me otherwise, but it feels to me that it takes a very long time for ALS to get there after BLS, generally speaking, correct? Do you have statistics around that?
Wait, for all cases, for
In general.
naloxone in general?
No, not just for naloxone, in general.
Our average response time for ALS is 6 minutes.
And that's everywhere in the county?
So 7
For all
minutes and
calls.
12 seconds.
Okay,
for
so I'm
all
hearing
calls.
outlier cases or seeing
And-
outlier
And
cases.
keep
Fair.
in mind, we have rural, suburban, and urban jurisdictions that we report our response times to. And we have
It's an
different
average of all.
thresholds, to be able to hold that too. So, in all fairness, when I give you 7 minutes and 12 seconds average response time, it's weighed by the 7,000 plus calls and 11,000 calls a year. So it's a weighted thing, statistics. And so it weights it just slightly faster. So for those involved in a response to Bucoda, or those involved in a response, as Dr. Fontanella referenced, down into the Bald Hills or south of Yelm, there will be potentially longer response time that, in terms of looking at it statistically, would just be smaller figures, but could be seen as a longer response time. Within the urban sector, though, as I reported, it's 5 minutes and 55 seconds on average within the
I
urban
understand that.
centers.
And yet
So-
when it's your father who waits 20
Yeah,
minutes, that's, okay.
I can appreciate
I said it
that.
was
Sure.
anecdotal.
Sure.
And then I have a question, and I understand everything you said. Don't agree necessarily, but understand it. There's a big difference here, though, in these charts that you shared. If Narcan is administered prior to EMS arrival, which I assume means on the scene by a bystander who has Narcan
Yes.
on them, right?
Or law enforcement.
Or law enforcement, 2% death rate, jumps up to 7% when it's administered by EMS.
Absolutely agree. With that being said, I have an answer to that in
Okay.
2 more slides.
Okay, I'll hold on to that then.
I'm really sorry.
No, I'll hold on to that, that jumps out. And then just because I work for a bureaucracy too, and I understand working for a bureaucracy, this is clearly an issue that you've decided to make a change on, whether people agree with it or not. That change will bring you into alignment with what other counties do, and it takes 18 months.
So,
Where are you in the process of that?
in terms of the development process, we're in the protocol development phase. As we go through it, that takes the majority of the time as we're going through this particular one, is the protocol development phase, and then discussing that with our training team, as well as making sure that we have the financial capability to support going from 13 different units that we supply Narcan to close to 40. And so making sure that we're addressing those financial components to make sure it's sustainable in the Medic One levy moving forward as well. So there's a couple of different factors as you're looking at it when you're looking at from a bureaucratic standpoint is really what's the process and identify how you're going to do it, what's the training implications of this for 650, and then ultimately what's sustainable in the Medic One levy funds as we move forward. And so all those factors have to be weighed in the process in terms of the development.
So you guys are in the early stages of, and on that chart on slide 12, you're in that first 6 month period, right? And somewhere in those first two blocks, or are you further than that plan?
So yes, this is a stepwise fashion. Unfortunately, it could be a circle or a variety of different perspectives.
That's fair.
We've already done some of the fiscal analysis and components ahead of this. And so when you're looking at this, it comes across as a stepwise fashion. I apologize, but
Some things
really,
happen in parallel.
some things are happening in parallel as we walk through it. So conversations with the state in terms of protocol development that you see on the next page, fiscal analysis in terms of what are the impacts to the Medic One levy to support naloxone and all of our providers. One of the things that I would call out is that the state defined by the Office of Financial Management what is a rural county and what is an urban county, or a not rural county in terms of where they will support EMS naloxone. We actually fall outside of that arena. So we don't count as a rural county, even though we have sections of our county that are rural. We fall outside of that in terms of the naloxone that would be provided to those counties in
We get less
EMS
funding.
as well. So that would be need to be supported on the Medic One levy front. And so there's a variety of different components there, so.
No, that's helpful.
And you already have director's approval for it.
Did you ask all your questions? Okay. Commissioner Mejia had a question, and I want to let you proceed with your slides, because we keep asking things that are like on the slide right after this.
She had a good presentation.
And I'm sorry if you've already said this, but I'm wondering, right, as we're talking about BLS and Narcan admission, I'm like, how many other counties use BLS to give Narcan and do the leave behind?
I cannot answer, and to Commissioner Fournier's point, there are 38 other counties that do BLS Narcan. But in terms of leave behind Narcan, I honestly could not speak to that number.
I don't know.
We're modeling off of Tacoma Fire Department in terms of what our protocols and processes look like in that protocolization process.
We should also mention there is only one other tiered system in the state.
Yes.
So most other systems don't have the tiers that we do with BLS and ALS. So you may only get an EMT if you're in Prosser or in Enumclaw or many other places.
Can I ask just a quick follow-up? And never mind, I just blanked. Go ahead.
When it comes to you,
When
let
it
us know.
comes
Ty.
Can we hear your response that you were?
Sure, I mean, I'm debating whether, just because I know it's a heated, emotional conversation for a lot of folks. Part of my response is 38 other counties do it differently, but there's only one other system that has a tiered system that would be comparable to us. And the MPD from that system has told me that he's jealous of ours, but he can't make it fly politically. It's not for the medical benefit. So that makes me feel a little better. But the second thing is there's no data that says that that is the better way of doing things. And I'm afraid that we're gonna lose more patients because we're gonna lose them to the 15% mortality in a year if we don't get them into the hospital. That is my concern. As far as, I do know it's been a source of pride or an insult to our providers' pride that the EMTs can't carry Narcan. And it's not that I don't have faith in them. It's never been. It's an easy skill. It's always been about the bigger picture. The reason why we're giving it to every City of Olympia employee is because they can't bag valve mask patients. If we could administer bag valve masks, I think that would actually be great. And then we could titrate Narcan to then get people into the hospital where they can get help. So that's some of my responses. But again, I don't think it's fair to say 38 other counties are doing it differently. Why, I'm glad we're finally doing the right thing, because I don't know it's the right thing.
I desperately want to
Sure.
let you continue with the slides, but I have just one question, maybe short. In the study that you cited that was done, I think in Boston, it is a study of the mortality rate in the first 3 days and then the rest of the year for people who had naloxone administered. Do we have a comparison data set of people who didn't have naloxone administered? Because you're referring to these mortality statistics, but what are we referring to them against? Like, what's the mortality rate of someone who overdosed and did not receive naloxone?
I don't think anyone knows the answer to that. Some will survive, but I don't know, I don't know the answer to that. Yeah.
Can you find the answer?
I don't think it's
Bring
been
it back?
studied. It would be hard to get that study approved, where you would knowingly withhold naloxone, like in perpetuity, from a patient that would be overdosed on opiates. Because that's how you'd have to do it to find what the mortality is. So I don't know that that's a number that we can get.
You wouldn't get the human subjects review approval for that study. Fair. Okay, let me let you get back to your presentation.
And these estimates, by the way, are probably low. I mean, so the other part of the study, I mean, it's the best design study that we have to go by so far. But they excluded, if Boston EMS gave naloxone to a patient that had received it 6 months prior, those patients were excluded. So there were some repeat patients that would excluded and actually would probably drive the mortality rate up high. But for the purpose of this analysis, they felt it would give them a cleaner sample size to exclude those prior 6 months naloxone distribution. They also couldn't account for if patients were administered naloxone, but they were not residents of Massachusetts, or if they had traveled outside of the state after that, because all the mortality came from their basically death certificates.
If they gathered identity information at the scene when they administered the naloxone and then later on from a
Matched
coroner's
it with
report.
coroner's reports, correct.
All right, can we switch to the next slide? I'm gonna make these last couple slides fairly quick. The reason that I put up cardiac arrest survival and I put up the chain of survival is one of the initiatives that we're gonna be working together to make sure that we're improving that messaging. We know that early activation of the 911 system saves lives. It doesn't matter whether it's a stroke, whether it's a heart attack, whether it's cardiac arrest, or whether it's an opioid overdose. And that's something that we need to be very, very clear in our messaging out to the general public as to what the expectations are. When we're discussing, and the reason that I put in cardiac arrest survival into this slide is actually directly related to the statistic that you brought up, is that we went in and did a deep dive in all of those mortalities that we had in every single, it didn't matter whether it was prior to EMS or after EMS, the call to 911 was not made early enough to have affected survival. And so when we have an individual that has an opioid overdose, they go through the process of respiratory arrest followed by cardiac arrest. Naloxone does not work when a person's heart has stopped, period. And what we need to do is make sure that we're engaging with the public, that when we have these individuals, the increase in mortality related to EMS arrival was directly related to a lack of calling, early activation of 911 to have all those resources available. That these had actually fallen into a category of being in cardiac arrest. They needed chest compressions and they needed an alternative care pathway than the naloxone that was provided on scene. It just was not working, regardless of whether it was provided by EMS or provided by prior to arrival. With that being said, I'd like to point out Thurston County has a very, very proud history of its cardiac arrest survival. When we're walking through the process, one thing that I want to call out, and there's about 7 times that you can hit the space bar to speed this up a little bit, but of the 308 resuscitations that we attempted, 63% of those had bystander CPR, and we encourage the use of bystander initiatives. We are not dissuading the increase in naloxone being provided by our citizens. This is part of the response process. In addition, we had an increase, almost a five-fold increase in public use AEDs, which also includes our law enforcement AEDs and getting them integrated into the process. This, again, we have a long history of making sure we integrate law enforcement into these initiatives. And not only do we look at that from a CPR standpoint, but we look at it from a naloxone standpoint as well. When you slide into the EMS response, 70% of those patients that we responded to in this arena regained pulses, which is pretty fantastic to have a ROSC response for those that were witnessed arrests that had shockable rhythms that were treatable. We had a 70% ROSC on those individuals that we transported in the hospital, which is a remarkable statistic. When you're looking at hospital care and survival to discharge, in 2023, we had 42% of those that were witnessed by a bystander, had started CPR, had a shockable rhythm, and that EMS transported in the hospital. You almost had a coin flip as to those that would be able to be transported into the hospital. And that's remarkable. So when you're looking at a system and looking at early activation and integration of this, I wanted to call out that we also sometimes forget or we think, oh, we're just doing CPR when we're looking at can you survive to discharge. But the last thing I like to call out is that every single one of those individuals that survived a discharge in this algorithm had 100% of those in 2023 were neurologically intact. They walked out and were able to be with their loved ones and active members of our community. And the important part of this that I like to call home, and I'll open it up for questions, is actually as we slide to the next slide, it's not about all the statistics that we have been talking about today. This entire talk today has been a mess of statistics. But with that being said, this is the graph that matters. Because these are the numbers of people that we're sending home. And when you look at pre-initiative, pre-activation, pre-chain of survival, pre-systematic initiatives throughout the entire system, and very clear messaging, we're saving between 2 and 4 a year. And when we step into the arena of making sure we have a very clear, defined, communicated, in-line message, we can do astronomical things for our community. And these are the numbers of people that are walking home. And so that's what I wanted to leave it with.
VF on arrival.
These are all
it's a shock.
Sorry.
It's a certain type of dysrhythmia. It's when
Yes.
your heart is fibrillating, ventricular fibrillation.
these stats, however, are not overdose stats. They're
No,
all cardiac stats.
I wanted to tie
Cardiac
it
arrest.
with early activation and really impress on this group the reason why we want to make sure that we're activating the EMS system. And to tie it back to, I saw you had some consternation over.
It's not consternation, I'm still not understanding.
I was gonna try to illustrate,
Yeah,
because I
please.
think Ben touched on it, but I think it goes back to, in our deep dive analysis, we were finding multiple cases or a trend of patients that would receive naloxone from family or friends without ever calling 911. So they would give the Narcan hoping it would wake them up and wait, and then maybe give them another dose and wait. And all that time, minutes are going by where they're either hypoxic or in cardiac arrest already. And so when EMS gets there, we already have a patient that's not salvageable.
And yet that death rate is 2%. And the death rate when Narcan is given by EMS is 7%.
Right,
That's
because
the part I'm
we're
not
yeah,
understanding.
there's a selection bias in the cases that EMS is getting there because, oh, I see what you're saying. I'm sorry. It's because we were getting there later in the course of their illness. I'm not explaining this well enough. You
So
try.
in terms of the way the statistics were pulled, what I think would answer your question is that any time that Narcan was administered by EMS, it fell into the EMS given Narcan category, even if it was
Even if
prior
it was
to.
given.
Correct.
So the
It didn't-
selection
yes.
involved was that what you're seeing is a selection bias towards if EMS themselves in any point in time gave naloxone, whether it was during the resuscitative efforts or not, it fell into the EMS category. So there was a selection bias towards the
And
EMS.
so you're saying that the EMS given cases, in your opinion, were because of delay in.
And that's after going back and
response?
reviewing when, actually listening to TCOM recordings regarding
That makes sense.
when they called and under what circumstances.
Commissioner Fournier?
I just want to say, like, you're talking about response times and average response times. and the outliers. I represent constituents that are the outliers. You know, like we live the furthest away from where medic units are stored, you know, when they're, you know, people are living out Skookumchuck or way out in the middle of nowhere. And it's not 7 minutes, it's 15 minutes, it's 20 minutes before an ALS unit gets there. And so, you know, not only do I think that BLS Narcan is important, I will likely be asking for discussions about BLS IVs, BLS fluid replacement, because in my mind, the more skills that can be given to, you know, the providers that are out the furthest away, that, you know, the better outcomes we're going to see. So like, I appreciate this discussion, and I hope to push for more pushing down of skills and releasing of skills.
Thank you. Have you reached the end of your presentation? We'll let you get all the way to the end. Okay. This has been really helpful for me. I mean, I could ask a whole bunch more questions.
I'm sorry,
So I want
I
to
have to
respect
run.
your
I
time,
apologize.
yes. One question, Ben, I think that you may know the answer to. What is the difference between the response time for BLS versus ALS? Because ALS is 7-something minutes aggregated over the whole county.
Yes.
What is BLS?
BLS's average response time is actually slightly faster, which it should be because you have, think of the 7 units that we talked about, the districts, that overlays. So when you're looking at a tiered system, and we're one of 2 counties that actually do a tiered system, to Dr. Fontanella's point, that we have an overlay of ALS units that are 7 and about another 50 that are staffed in any given day that underlie that on the BLS side. So you're closer potentially to the call itself based on that configuration. With that being said, the perspective, we're actually closer to about 630 based on 2023 statistics for the average response time countywide. Again, we have 12 different districts, and in support of Commissioner Fournier's note that there are response time compliance differs by state WAC between rural, suburban, and urban areas. And so that's the overall average. I'm sorry, I cannot cite the 12 specifically.
Ben?
Another time. Go ahead, Commissioner Fournier.
Not Dr. Fournier. I just want to also, you know, kind of reiterate, there's been presentations in the past where there's been quite a bit of emphasis given to the fact that wait times are longer at the hospital, our ALS units are getting tied up, and we've been told that sometimes they'll sit at the hospital waiting to get a patient off their bed for as much as 45 minutes. So we are having to bring on an additional medic unit, and we're looking at using that to reduce response times. But there's also a real issue of units getting tied up at the ER and not being available to make those runs out to any of our jurisdictions.
And that was the thrust of my question, was sometimes is there a significant gap of time between BLS versus ALS response? And I know we're looking at aggregate numbers. I'm guessing sometimes there is a significant time difference.
At times, there are differences. For the most part, and in response to that, I think you're going to see some radical pivoting over the course of this year with the addition of 10 more ER beds that are supplying support to the community in the Lacey OSED or the off-campus ED. We've already seen tremendous.
Previous presentation to my council was in the back of my mind. I know we are addressing the issue of units getting stuck at the hospital.
Yep, and so we've seen on the early end a pretty significant rebalancing of where we transport our patients, which has also significantly decreased the wait times, as well as making sure that we have priority for our medic units to drop off those patients and quickly have a faster turnaround time. So from point of drop off to back in service. But at times when we have very high census or very high call volumes, at times it's unavoidable. So.
Referral to community providers might be one way to address that situation in the ER, and also those folks who are not going to the ER and leaving against medical advice. Being a crisis responder myself and working with that, what we oftentimes see is frequent contacts is what makes the difference. And so I don't want to know if that's part of the plan in the future, but I think it could be very helpful.
I think part of this discussion is actually part of this coordination. That part of the presentation and discussion we wanted to have here is that while we're dealing with an opioid epidemic, this is spanning a very, very large, virtually any medical provider and virtually touching almost all of our residents in terms of how we address this. And so as we coordinate this and as we move forward, we want to make sure we were communicating what our expectations and timetable and processes would be and how could we further coordinate.
Yeah, I think there's some really good follow-up conversations to be had about this idea of, I think we want to make sure that the system is moving forward with its changes, and so I appreciate Ben the update on the protocols where you're at, but I think to your point, Heidi, I think there, and Ben has made this comment too, it is about the entire sort of network of care in this county and how we're coordinating or not coordinating, right? And so I think this is a good sort of piece of the puzzle, but I think it's not the full puzzle, right? This isn't the end all be all, and your image of the bucket comes to mind again for the how you want to reduce mortality. So I think as a board, I think it would be worthwhile for us to think about those ways that we're connecting across the spectrum. So I appreciate that comment from Heidi.
And I do need to move us along on the agenda, so thank you so much.
Thank you very much for having us.
And also, I think that our hope is that at least on an annual basis, to be able to have this type of presentation, could be a different topic, but really trying to foster that cross-pollination.
Yeah. A lot of overlap of interests. All right, next item on the agenda, and I do want to note it's 5:17. We have 3 more items on the agenda, perhaps. I'm wondering if perhaps we want to push one of the whatever I want. Would those of you gathered here like a first review of the bylaws, or do we want to do a second review of the strategic plan if we needed to push one of those items to our next meeting? Show of hands for bylaws. Show of hands for second look at the strategic plan. All right. 3 people voted and they voted for the strategic plan. So we're gonna look at the strategic plan and
I had to pick one.
Your vote counts for more if nobody else votes. So please take us through the strategic plan and we'll take a look at the bylaws next time.
Great, thank you, Jen Fryhead, Assistant Director of PHSS. So I believe last time we approved the vision and mission and values. And so however far you want to take it, I stand at the ready to make any edits or work on any additional changes as we continue to move through and approve piece by piece, or how far you want to get through it.
I said it last time we met, and I'll say it again. We don't want perfect to be the enemy of good. So if we can get to a place where the language is tolerable and meets our broad goals, I think we should proceed with getting this done and finalized and posted.
I will point us so loosely on page 2, the vision, mission, and values. I think potentially some of the definitions of those values could be tweaked still yet, and maybe that comes in a later subcommittee or whatnot. But page 3 then really talks about the living process, how this will be carried forward, not just a plan sitting on a shelf. So that portion could be discussed, or it could turn to page 4 where it gets more into the tactical goals under each of those strategies. So I would suggest either 3 or 4, whichever topic you want to talk about today.
Page 3 or page 4?
Yeah.
Go ahead.
I was just gonna say page 4, because then it's early in the year and you could actually start work, yeah.
That makes good sense.
All right, so just to, for a quick review, you always have your vision first, the guiding star. Your mission is how you achieve your vision. Then you have strategies, and the strategies really loosely on page 4 there are data, policy, and education. Those are underlined just for the quick eye. And then some of the goals that were chosen were, again, loosely sort of aligned under each of those strategies. So the strategy is an easier way of saying the goals, whereas goal gets into a little bit more detail of how you then achieve that strategy. So for example, strategy 1 is to assess data to monitor population health. And so the goal, and again, I took liberties, so please however you want to massage this or change the wording is fine, is to increase data visibility in the community, considering that you're the Board of Health and you're the connection to the community. The Board of Health will be taking a more active role to review, understand, utilize data to inform ideas and to support the programs and services of Public Health and Social Services Department, and also looking at how data can be used to inform the community and increase awareness of public health issues. So it's largely data to the community, is what that's trying to convey. That one look okay?
Yes.
Are we using data other ways too?
I think that there's certainly more that could be expanded there, and what I was trying to do was simplify because it's a 2-year plan. So that doesn't mean looking at data in other ways is not acceptable, just trying not to load too much on, was where I was coming from. But if we could change, if you have a different.
Well, I mean, I really think data is important because it's gonna drive where you see the gaps are, what are the new things that are coming that you need to be getting on, and then also potentially long-term. And so, I mean, I think the visibility to community is always helpful so that you can communicate why you're doing the work you're doing. But I think like they did it today with the STI conversation, like it was very helpful to look at that data and then potentially be like, what programs are gaps in our community and where do we need to look for grants or, you know, other things. So if there's a way to kind of tie it to the work and tie it to the like future, that would be really helpful. And I don't know if you have to put that in words, but.
No, I can sort of see where that would be, look at data now so that there's a broad understanding of knowledge. And then that could be maybe the next strategic plan is then, okay, now we know, so now how do we carry that to the community? So it could be.
Well, and potentially, do we have a community dashboard and a Board of Health dashboard where we have certain data we're tracking that we're like, these are our 3 priorities we want to track this year, or, you know, I just think sometimes it really focuses your work too. I don't know if anyone else.
Well, would it be worthwhile to say not only that we're trying to increase data visibility in the community, but also the use of data in policy development and planning for the board? So not only are we trying to share more with the public, but we're trying to rely more on data when we make decisions or when we give suggestions or direction to the public health staff.
Would you like that as a goal, a second goal under that strategy? I would advise it being separate so that the goal 1.1 is not so long, that it's 2 separate sort of
Goal
initiatives.
1.2.
All right.
Share it, we're gonna use it. Data.
Sounds good.
I like it, thank you.
All right, then strategy 2 is basically innovation through policy and research. Establish a system for policy support and development. This is from what I gathered from the conversation of how can the Board of Health be more useful in policy, whether it's federal, state, or local policy. So it's basically looking at just how do we establish that system? What do you all do in this policy realm? With the onboarding of the new Board of Health clerk, known as the Policy Program Manager, the Board of Health seeks to champion public health policies and laws while increasing involvement in advocacy at the city, county, state levels. This could also lead to new partnerships with secondary education institutions. That was something that came out during our strategic planning session about working with secondary institutions.
It looks good to me. Does anybody have any comments or feedback on that one?
And as this gets further down into the action plan, that could, you could decide to have subcommittees that work on these various things, and then what's the action that goes beyond that? All right, strategy 3 was all around education and outreach. So this sort of teased out from the goals you chose into 2. Goal 3.1 is to build public trust, provide regular, timely, and effective information to the general public and partners. Basically, to sum up what it was saying here is to increase the public awareness as a consistent and authoritative resource, and the effective communication both in times of community and or public health emergencies. So really sort of that branding that we were talking about during the strategic planning. Yeah, accurate perception of the role and services of public health. right? Excuse me, goal 3.2 is to build and strengthen community partnerships, so it goes right sort of along with that. That was a big one that many of you chose as far as those collective impact strategies. Creating a plan, again, the preliminary sort of discussion of what is the entity as a Board of Health, creating that plan at the very early stages for partnerships and expanding and enhancing collaboration, also in conjunction with public health and social services. And these will have a focus on health and racial equity, including equitable access to care.
I think we saw sort of an example of the beginning of that today when we were talking about making sure that STI testing is available and finding opportunities for partnership that could benefit the community. So let's do more of that intentionally.
And that will also be the helpful goal of the Board of Health clerk too, as things come up or, with the EMS system or whatnot, to sort of say, okay, how do we plug those in and what strategic plan goals are they fulfilling? And will they fulfill so that you can continue to go down that path? All right, that was easy.
So,
I like it.
be
All right, good.
satisfied with page 4?
Sounds good. Just for a real quick cap up, page 5 is just describing what is on the framework that follows up on page 6. This is where I think that framework would best come in subcommittee or a smaller group work to really hammer through some of the details. So page 5 is just describing what you're finding on page 6 and beyond. So maybe next time we talk about subcommittees, and page 4 can come somewhere down the road of how do we continue the process of it. Sound good?
Nice.
We had a subcommittee, fiscal subcommittee, is that right? Did we form any others yet?
Nope. So
we actually added to the fiscal subcommittee, if I remember right.
you did add to the subcommittee, and then I think the idea that was laid out here was, as you're thinking about these goals and strategies, it might make sense to have subcommittees that are specific to the strategy or the goal. So they may not be standing subcommittees, right? They might be just ad hoc for this time period, but it makes sense. I like the idea of being able to have subcommittees that can work between these meetings to see movement and action on the work plans. But yes, right now you've got one standing committee, which is the fiscal subcommittee.
Shall we hope to wrap this up next time?
I hope.
Okay. You made good progress today. Nice work, team.
So when would be the timeline of the subcommittees? When would we start talking about that?
Well, the thought is that this is, as soon as it's approved, it's live. So wrapping up the living process in those subcommittees at the next meeting, it could begin immediately after that. So
Everyone come prepared with your calendar next time, because maybe you'll have an opportunity to volunteer on a subcommittee.
okay, sounds good. Thank you.
Jackie. All right, we've reached the health officer's report. Great.
I know that this has been a bit of a long meeting, so this will be a high-level overview, and I'm happy to answer questions. I know we've sent out a lot of communicable disease-related messaging this month since our last meeting. I did want to start out talking about viral respiratory illness, COVID-19, RSV, and influenza. We are below the minimum alert thresholds. And for all three, we are seeing low levels of COVID-19 in our wastewater detection through LOT, which is also reassuring. Influenza activity is minimal in Washington State, largely flu A. I know folks are looking at me in my mask. This is not this is a result of a non-COVID viral respiratory illness for which I am well out of the infectious period, but this helps me to transition a little bit into the new guidance around viral respiratory illnesses that so we in Thurston County are in alignment with DOH and CDC, which looks at viral respiratory illnesses more globally and recommends isolation when you have a viral respiratory illness at home, for folks to isolate at home until their symptoms are improving and they've been fever-free for 24 hours without use of fever-reducing medications. this is guidance for the general public. It doesn't cover healthcare, which still has very particular isolation precautions, and for influenza, it gets much more complicated in the healthcare setting just because folks are medically fragile. But the other caveat is that it doesn't include certain congregate settings such as corrections and shelters for houseless folks. And that's because, when folks are in close proximity, it's much easier for viruses, especially COVID-19, to spread. So there's still a isolation requirement that's days-based for COVID-19 in those settings. The other place where there may be a days-based isolation period has to do with certain types of COVID-19 outbreaks. And so it gets determined based on what other protective and preventative measures to prevent ongoing transmission there are in a particular setting. So that's the only other real place where you might see a days-based situation, or if we're seeing severe disease, something that's not, something that's beyond ordinary, would be another place where we might have more protective measures. I did want to say that the new guidance does have some recommendations for when you're working with folks that are immunocompromised, or have, folks in your life who might be immunocompromised or at severe risk of COVID-19, or of severe illness from COVID-19. And that does, the recommendation in those settings is, if you can isolate away from that particular person who's at high risk or group of folks for 10 days, just as we have been for a significant period of time, do that. If you can't isolate away from them, the next most protective thing to do is, once you've met criteria to end isolation, is to wear a mask when you're around them. And then just thinking about, we've had guidance around exposure. So if we're exposed to a viral respiratory illness, what to do. The days-based the days-based requirement has transitioned for the general public. And it's recommended that folks consider wearing a mask, just to reduce the chance of transmitting the virus onto someone else before we're fully aware that we're sick. In those first days where, sometimes folks are debating, is it allergies? Is it COVID? Making sure that we mask and then isolate when we're symptomatic is really key. The guidance also kind of takes a more holistic approach, even beyond masking. So thinking about, ventilation, improving airflow, hand hygiene, cleaning of high-touch surfaces, distancing, and testing are all things that mitigate risk in these settings. And then the other piece is thinking about folks who are immunocompromised. Is that if somebody knows that they've been exposed to COVID-19, really consider staying away from people who are at high risk for 5 days after that exposure. Although you can become sick up to 10 to 14 days, post-exposure for COVID, most people develop symptoms earlier on. And so if you can, definitely consider doing that. And if you need to be around somebody during that period who's at high risk of severe disease, wear a mask. So I did want to transition. So that's kind of the big broad news. I did want to transition to talk a little bit about a Shiga toxin producing E. coli outbreak that's been associated with raw milk and cream, at the Cozyville Creamery. There is a recall of the raw milk and cream products with best by dates of March 18th, 2024 to March 28th, 2024. And these were raw milk products that were sold at different shops in our county. To date, there have been Washington residents from 3 different counties that have been included in this outbreak, including Grays Harbor, Pierce, and then there's been a case in Thurston. So, my ask is that if folks have the Cozyville Creamery products at home that are from this recall period of March 18th to March 28th of this year, to not drink them, throw them away, or they can return them to where they bought them for a refund. So E. coli infections can cause, serious complications, which is why we worry about them. So diarrhea, stomach cramps, and blood in the stool. Some folks may have a low-grade fever. And then for this particular type of E. coli infection, STEC, some folks, including children, may get a type of kidney failure called hemolytic uremic syndrome. And so that's, it's fairly, when it occurs, it is fairly serious. So that's why we're really wanting to caution folks about raw milk products.
It's to be avoided. Commissioner Fournier has his hand up. Go ahead.
Yes, thank you. I don't know if this is even a question that can be answered, but I seem to recall that that specific creamery has had multiple incidences of E. coli from their, I believe it's minimum pasteurized milk. And this might be the second or third E. coli outbreak from that creamery. How does that work? Is there some pasteurization process that the county ensures, or the Department of Health ensures is conducted for you to be able to sell it in a store?
So I believe the WSDA works with creameries on the creamery safety side of it. For this particular creamery, this is the second recall associated with this outbreak, and cases started to pop up, I believe, around February, potentially as early as January of this year. So this is the second. So we've had 2 recalls associated with this particular.
In the last year, or the other incident I recall, it was 10 years ago, and there were children that were harmed.
So is this a question for the Washington State Department of Agriculture?
As far as the regulatory side, that's my.
Yeah, Commissioner, I'll follow up. It's a good question.
Thank you.
Final words, Dr. A.
Pardon?
Final words, Dr. A.
One last thing that I wanted to put on folks' radar is that the CDC did mention a second human case of highly pathogenic avian influenza, a second U.S. case. The first case was in 2022. Where in someone who'd worked with an infected flock of birds. This most recent case occurred in a farm worker on a commercial dairy farm in Texas. Folks have looked at the genetic sequencing of the particular flu strain. They're not seeing mutations that would present a significantly increased risk to mammals, which is in particularly humans, which is good. And there's some recommendations for providers as well, just in terms of how to if such a case, which the risk right now is extremely low, as in one human case in 2022 and a second human cases in 2024, and the CDC and all of us in public health are helping ensure that folks have the information they need, so that if they see somebody, there's resources available for how to best mitigate. And with that, I think those are kind of the main things happening in our neck of the woods, and I'm happy to answer any questions.
Going back to your first topic, really practical question. Start to get a cold. Is it, at this juncture, is it important to immediately do a COVID test? And if so, is that because what? Because it's days-based quarantine, not symptom-based quarantine, or what? Is that even important anymore? To know if it's flu, cold, RSV, I don't know the difference, but you know, in your families, you get kids cycling through, and I just didn't know whether to put the thumb on them and make sure everyone's COVID tested immediately, or if that doesn't really matter now.
So I still recommend COVID testing. Part of it has to do with kind of how infectious COVID is compared to other viral respiratory illnesses. So there's a significant, an increased transmission risk. And then knowing whether or not folks have COVID also helps folks know whether or not to seek additional treatment. So thinking about folks that qualify for Paxlovid, which saves lives, and we're still seeing a significant number of COVID deaths in Washington State, significantly more than influenza or RSV deaths, across the same time period. So I would, I typically recommend, testing for COVID, early on. And for myself, if I test negative and I still have symptoms, I will retest, 36 to 48 hours later, because I'm using an antigen test. And then if I'm still having symptoms and, and I haven't, improved and I'm still, having a fever, then I personally will even test a third time, just to make sure.
But if you test and you're positive, what do you do differently if you're not one of the people that's severely injured or immunocompromised? I mean, should the kids not be going to school? You start masking, I would assume.
Yeah, so I guess if you're not somebody who's, severely immunocompromised, so it's good to know so that you know what your risk might be to someone who is. But in terms of what folks, how folks take care of themselves, that guidance has largely merged, with other respiratory illnesses. So stay home until you're feeling better, fever-free for 24 hours, and then mask for an additional 5 days after you've met the end of the isolation criteria.
All right, thank you.
Gonna move on to the next item on the agenda, which is our director's report.
I'm just here to wrap it up. So I'm really grateful for the board and your time here. I think the conversations we had today were robust, whether it was the STI proclamation or it was the conversation about BLS and naloxone. I think I appreciate the board's patience as we are, as a group, going through our processes of developing plans and bylaws. And this is not the fun, sexy part, but I think getting this stuff settled and then the board having opportunities to be structured in the right way will be helpful. So I think we're moving. And so I think starting next month, it'll be great to sort of see committees formed and steps taken. The only thing I wanted to call out today was actually in the back of the room, we have our new county manager, Leonard Hernandez. So I wanted the board to be introduced to him. If you want to say anything, I would give you the remainder of this time.
Thank you so much. I look forward to meeting you in person as the meeting adjourns and working with you.
That's it for me.
Thank you. Yeah, it's not the fun, sexy part yet, but it is the foundation building. That's what we're doing here, so. Thank you, everybody, and without objection, I'm gonna call this meeting adjourned, because I have to get across town.
Thank you.